Yes, one.
Okay, so welcome everybody. This is, I think maybe the fourth or fifth time we've done this hemodynamics seminar, and it's always good fun for us as the speakers. I always learn a lot from listening to both Gorm and Isfan, and looking forward to listening to Shahab as well. You'll find that the ability of people to actually give comment, as Gorm's already done, is really useful, and you'll get some really good clinical insights from the input of the speakers, and eventually we're expecting you guys to be inputting as well. That's part of the tradition of this seminar, is that as you feel more confident, we need you to be asking questions and challenging us a little. Okay, first question from me though is, who in the audience is neonatology? Pediatric cardiology? One or two, that's great. Anybody else apart from neonatologists and pediatric cardiologists? And the other question I had for you is, who uses ultrasound at the bedside to help manage their babies? So about half, 1/3 to 1/2. Okay, so the first talk I'm going to talk about is the use of ultrasound at the bedside to help make treatment decisions and many other things, and hopefully convince the 2/3 or half of you who aren't yet using it that it's a worthwhile skill, that you should be trying to seek out a way to learn how to do it. And at the end of the talk, I'll talk a little bit about training and accreditation and resources, all of which are in the talk that was uploaded onto the website earlier. So I'll cover a little bit about the history of the use of ultrasound briefly, terminology and politics, which is, I think, an important issue. Israel's already alluded to this, particularly if you're trying to access this in your own unit. There may be some things that you need to work through with access to ultrasound machines and interaction with other specialties, radiology and paediatric cardiologists. Talk a little bit about why we might want to use ultrasound because of some of the limitations Isfan's already talked about the assessment of the cardiovascular system in the neonate. Go through the uses in the NICU, training accreditation, and then talk a little bit about the training systems that are currently being set up, the one that we have in Australia and New Zealand, and then looking at the recently published guidelines for North America and Europe, which covers here as well, and just see whether you guys have come across those guidelines and if we can see any barriers to their implementation. Start with a case. So this is a typical baby that we might be looking after in our nursery, 25 weeks, 760 grams. This baby is 8 hours old, and the blood pressure is 30/18 with a mean of 23. Who would classify this 25-weeker with a mean of 23 as having hypotension? Anybody? We don't need to talk anymore. So we'll talk about definitions of hypotension tomorrow, but most people would say that a baby's mean blood pressure under the gestational age is hypotension, certainly below the 10th percentile for the population norm. And this baby, however, has normal heart rate and normal capillary refill time, well, borderline capillary refill time, 2 to 3 seconds. So the treatment choices we might have in this setting with a baby with borderline or low blood pressure is to do nothing, which presumably those of you who don't believe this is hypotension would do. As Isfan was saying, often our first management step is the use of volume in the setting of hypotension, or use of an inotrode. And we have different choices, but the two most commonly used inotrodes would probably be dopamine and dobutamine. So there's a few different treatment choices. So if instead of choosing one of those, we get some extra information about the baby's underlying physiology. If we do an ultrasound on this baby, this is a real baby we had in our nursery a year or two ago. This baby's cardiac output measured at 350 mils per kilo per minute, which is a little bit higher than the normal range. This baby's got a large PDA with a systemic to pulmonary shunt, left to right shunt. The function of the heart looked normal, so there wasn't impaired contractility, and there was a slightly dilated left ventricle, so the left side of the heart's a little bit volume loaded, presumably because of the left to right ductal shunt, and the structural screen of the heart was normal. So, does that change our treatment choices? Getting that extra bit of information? Give us a little bit more guidance. So if we went through our choices now, the option of doing nothing is now a little bit more appealing, though disappointing that most of you didn't feel it was hypotension, because a lot of people, I think, would still be treating that baby with something. But now that we know the cardiac output is normal, then we've got more to back up not treating this baby, because Isfan's already pointed out that the main determinant of systemic and organ oxygen delivery is not the blood pressure but the cardiac output, and this baby has a normal cardiac output, though there are a few issues we could talk about as to what a normal cardiac output is in a baby with a large PDA. The question about giving volume is a little bit less appealing now, because if we've got a baby who's already a little bit volume loaded and we can see evidence of that occurring, giving more volume may drive that left to right shunt and make this baby become more volume overloaded. Question about inotrope. If we did want to choose an inotrope, it may be in this setting that dopamine, in the setting of a normal contractility and a baby who's got a high cardiac output and a lowish blood pressure, as Isfan's already alluded to, a baby who is presumably a little vasodilated or got low combined systemic pulmonary vascular resistance, then using a more vasoconstricting inotrope, if we were going to use anything at all, would make more sense. And then there's the whole question about whether the underlying cause of this borderline hypotension is actually the patent ductus arteriosus. And therefore, there's a whole talk we could go through about whether we should be treating the PDA or not. That's a new piece of information. This baby's only 8 hours old. It's not 3 days old with a murmur. 8 hours old. Okay. So, do people feel, having just demonstrated that this information in yellow is helpful in this setting? Yes? Anybody disagree? Excellent. So, echocardiography in the NICU, this is echocardiography traditionally as provided by our paediatric cardiology colleagues, is usually a consultative service. By that I mean the clinician or the consultant comes to the neonatal unit, usually at a time that suits their schedule, not necessarily at the time when the baby is sick or you need the physiological information. And this is a generalisation, because there are certainly some units where they have very, very high level paediatric cardiology cover. But for example, in my unit, my cardiologist is 25 kilometres away, and it's a big issue for him to come and provide some information about what's going on with the heart. And the other thing is, it's provided by non-neonatologists, so even though they may have a good grasp of neonatology, they're not the clinician at the bedside who has seen the course of the baby up until the ultrasound is done, and also who sees the results of whatever treatment is instituted. So it's provided by non-neonatologists, cross-sectional, often one-off, so it's harder to get, I've found, again a generalisation, but harder to get our cardiology colleagues to come back to the unit every day, for example, to assess a ductus, because once they've seen that the heart is structurally normal, that's a primary aim for them. Again, some cardiologists are very interested in cardiovascular physiology and are prepared to offer that service, but generally they're focused on structural heart disease exclusion, which usually just takes the one consultation. We've talked a little bit about the timing. So if we look at the use of ultrasound by clinicians, certainly cranial ultrasound was probably the first ultrasound technique that started to be used, and certainly in Europe there's a long history of clinicians doing their own cranial ultrasounds for obvious reasons, similar reasons to why we might take up cardiac ultrasound, and that's getting information at the time we need it, which is usually in the middle of the night when a baby has deteriorated. Finding out about what's going on from the cranial ultrasound point of view is important. And then over the last 12 to 15 years there's been the emergence of the use of point-of-care ultrasound or echocardiography. We'll talk about terminology shortly, by the clinician. So This has been particularly with the improvement in ultrasound technology. So machines have become easier to use, more portable. The algorithms and the usefulness of cardiac ultrasound and the accessibility by people who aren't highly trained has become easier. And so that's driven the use of ultrasound of the heart, not just of the brain. Initially that was research in normal values, as any new technique would be, and we've spent a lot of time, our unit and many others have contributed a large amount of literature about what normal is, some new techniques. The important thing to remember is a lot of that has been contributed by neonatologists using ultrasound. It's not an area that cardiologists have contributed large amounts to, and they have at the beginning, but that's been driven in the last 10 years by neonatologists particularly. So, what about other areas? The critical use of ultrasound in critical care areas is becoming very commonplace now. So, in the adult intensive care unit, it's very common that adults intensivists would use ultrasound to assess filling and cardiac function. Becoming more common in the paediatric ICU, certainly in accident or emergency for triaging patients who present with shock and other potential cardiovascular problems. Anesthesiology, very commonly used. In fact, in the United Kingdom, more than 90% of all the transesophageal echo is done by anesthesiologists, not by cardiologists now. So, and these specialties have developed their own training courses and certification as well. So, use of ultrasound in critical areas is happening in many other areas. So, what's different about the NICU? Why has there been this difficulty with accessing ultrasound, particularly ultrasound of the heart? I'm talking about now the NICU, and there's been conflict between neonatologists and paediatric cardiologists about the role of who should be using ultrasound to assess heart function as well as structure. So why is it different to these other areas? Well, I think one of the problems is the concern that structural heart disease is also presenting in this time frame. So in the neonatal unit, that's the time when structural heart disease presents, a fair proportion of it, and so rightly so, cardiologists are concerned that if neonatologists start using ultrasound to diagnose structural heart disease, there may be missed structural heart disease. There's been a traditional strong consultative role for the cardiologist, so it's been the cardiologist who's had control of the ultrasound machine and use the ultrasound machine to look at the heart. And I think sometimes there is difficulty understanding that there may be a more extended use of ultrasound apart from just structural heart disease. And so there's that role model there. A lack of understanding about what the neonatologist needs and the potential uses, and that's because a lot of the literature and the information about the use of ultrasound in NICU has been driven by the neonatologists, and cardiologists may not even be aware of some of that literature, I've found. And there's also a trouble with lack of skills and training programs and access for our neonatologists. But things are changing, and there's been a series of articles, some from our group in Sydney and from others as well, including Shahab and Patrick McNamara. So there's groups around the world who've started to write about the use of echocardiography or ultrasound as a clinical tool for the neonatologist. And there's lots of good summary articles now which give you an idea about the breadth of what we use ultrasound for. So just a word on terminology. I've already myself chopped and changed a little bit between echocardiography and ultrasound. We in Australia have started to move away from the term echocardiography for what neonatologists are doing, because this is a term that it really refers to the cardiologist's main thing that they do when they're using ultrasound. And I think it's clearer in some ways to move away from saying that we're using echocardiography and start to use more generic terms. And that makes a lot of sense, because we're not focused on the echocardiogram and the structural heart disease. We're often focused on a much broader range of things. So the other problem with echocardiography is it implies a full structural assessment and a full study, and we may not have done a full study. We may still have to look at structure, but it's a responsibility for us if we are claiming that an ultrasound we've done to look at the PDA or to look at contractility is an echocardiogram, because that may then mean that people feel this baby has had structural heart disease excluded when that has not been the case. So we're moving away from this term. We coined the term functional echocardiography to move away from structure towards function, but even this has got the term echocardiography in it. The consensus guidelines, which we'll discuss towards the end for North America and Europe, use the term targeted neonatal echocardiography, again a version of echocardiography with the same problems, potentially. Point of care ultrasound is the term used by many of the other specialties for what a clinician using ultrasound to guide treatment at the bedside is doing, and so that's maybe a little more appropriate. Where we've moved towards, which is a little bit more specific, clinician-performed ultrasound, or CPU. And with this term, we can specify what we're doing. So, and I think this is becoming more important, so we understand, or people who look at what this baby's had done, understands what has occurred. So this baby's had a CPU to assess the PDA. So it's focused or targeted on the PDA size and significance. And it's not claiming to have done more than that. So this is more the terminology that we feel is more going to be appropriate moving forward. It does not carry the implications of a complete echocardiogram, and we found it to be acceptable to both radiologists and cardiologists in our setting. So just to summarise, echocardiography in the NICU, if we now start to separate out those two terms, consultative, non-neonatologist, cross-sectional, focused on structural heart disease. The other thing is that a high percentage of echocardiograms will actually find structural heart disease, because there's a referral bias. The reason we ask the cardiologist to come quite often is because we're thinking about structural heart disease. So cardiologists naturally feel that if they're coming to the unit to do an echocardiogram, that structural heart disease is going to be a high percentage. In fact, if we look at our clinician-performed ultrasounds and a recent audit, which I'll talk about at the end of the talk, only 2% of all of the CPUs had any structural heart disease. So 98% of the ultrasounds we do have not got anything to do with structural heart disease. And I think the referral bias often misleads others who come to the unit to do ultrasound to feel that structural heart disease is a lot more common when we're doing ultrasound than what we find when we're using it the way we use it. And we've talked about the timing, and the other issue is it's often an off-site service. So things are a little bit different if you've got on-site paediatric cardiologists, because they are going to be more available and often more engaged with the management. So that's great if you have that. If you don't have that, then is there a role for the neonatologist to develop more skills with ultrasound? CPU, bedside when needed. It's an extension of the physical examination, so we're using it to help understand the physiology of the patient. Performed and interpreted by the clinician, then integrated into the clinical scenario. Again, a little different to that with the role of a consultant who comes and provides some specific information, which is very high level, but may not be as integrated into the clinical situation. That's then up to you, the clinician, to do that. Predominantly functional, diagnose and monitor pathophysiology, target treatment to physiology, so we now get other extensions of what we're able to do with this information. Longitudinally follow up babies is very important. So there's a feedback loop here. We can learn about which types of babies will respond in certain ways. And we've certainly found that we have a much bigger or much better understanding of why certain babies don't respond to INO, or why babies respond in different ways to dopamine and dobutamine. And often the underlying reasons for that are explained by the physiology. And importantly, let's not forget that much of the research, the newer techniques and the publications have been led by neonatologists. So do neonatologists want access to this? This is a survey, well, the surveys in our country show that more than 90% now of NICUs in Australia and New Zealand have at least one neonatologist who can perform CPU. That's up from about 40% 10 years ago, so there's been a rapid take-up of this in Australia, and part of that is because we have a training program now. This is some data from a comparison study that's about to be published looking at the management of pulmonary hypertension, PPHN, in Canada versus Australia and New Zealand. And you can see that in Canada, about 80% of neonatologists would like to use echocardiography to guide treatment, and that's often provided by the cardiologist. Though it can be provided by the clinician. And in Australia and New Zealand, it's more than 90% use ultrasound to guide treatment. This does not exclude structural heart disease, it's actually to make clinical decisions And in Australia and New Zealand, a lot of that would be provided by the clinician themselves rather than by external consultant. So, why is ultrasound potentially very useful to neonatology? We're in a complex setting. Fetal to neonatal transition is occurring in the neonatal unit, particularly in the first few days. The circulatory transition is quite complex. It's affected by many things. We have cardiorespiratory interactions, so what we're doing to the lungs can affect the cardiac function. Shunting through the fetal channels, the ductus arteriosus, the PFO. Changes in the systemic and pulmonary resistance, often rapid changes. When we give surfactant, for example, suddenly the pulmonary vascular resistance drops. Or if we give an inotrope, we may actually increase the systemic vascular resistance. So there's rapid changes in resistance. We have an immature myocardium, particularly in the preterm infant. And that myocardium we'll discuss a little in one of the other talks, but the myocardium is not good with dealing with afterload and high peripheral vascular resistance. And often cardiac output will drop, even though the blood pressure is sustained, a bit like the case that István's just taken you through. And the whole situation is dynamic, so many of these things are happening together rapidly, and there's problems with cardiovascular. The cardiovascular system can result in significant morbidities, including interventricular hemorrhage, pulmonary hemorrhage, and maybe longer-term neurodevelopmental disability. So to understand all these interactions dynamically, that's what hemodynamics is, understanding things as they're happening, is potentially very useful for us as intensive care physicians. We've got many things to help us assess the cardiovascular compromise in individuals, and most of these are also applicable within the neonate, ranging from capillary refill time, core peripheral temperatures, some of the things István had on his complex diagram, specific organ perfusion, which we'll talk a lot about with Gorm here. And this, may be a very important part of our assessment, actually what's getting to the organs, rather than trying to work that out from cardiac output. We've got the more central measures. Of course, systemic blood pressure is the one that's most utilised because it's easy to obtain and continuous if you use invasive. And then we have the question about cardiac output and then other ways to assess. But if we look at how good these assessments are compared to measures of systemic blood flow, in this case we've used this measure, superior vena cava flow, which I'll talk about shortly. It's a measure of cardiac output which correlates with both left and right ventricular output. But here on this axis will be the parameter that we're looking at, in this case capillary refill time. This is a large cohort of babies under 30 weeks, and if we look, there's really very little relationship between the capillary refill time and measures of systemic blood flow. There's maybe a little bit more as we get into very extreme measures, so cap refill time more than 4 or 5 seconds, then it's getting a little bit more reliable at picking up low cardiac output. But apart from that, there's really not a good relationship. And we could go through all the other things, the core peripheral temperature difference against SVC flow, base deficit, and István's already mentioned one reason why that might be, the issue about the delay. So often lactic acid and base deficit there's a reduction in oxygen delivery to the tissues. We get the reaction to that at the time, but it may take 2, 3, 4 hours for that to actually show in the baby. So this may explain the simultaneous measurement disconnect. And then mean blood pressure, we'll talk a little bit more about this, but even blood pressure does not correlate very well with cardiac output. So if we're using blood pressure to tell us about what the oxygen delivery to the tissues is, and cardiac output's a main determinant of that, then it may not be giving us the information we think it is. And this, we can look at some of the summaries of this data, looking at sensitivity, specificity, positive, negative, predictive value for certain parameters that we often use in the unit, mean blood pressure less than 30, mean blood pressure less than the gestational age. And in general, the specificity and sensitivities are not particularly good. It's not until we get to quite extreme measures, as I mentioned, that we start to be more specific for low cardiac output. Apart from that, we may miss low cardiac output by using lesser measures. Others have found the same thing, so the correlation, so the lower the R is, the worse the correlation.